Hello, everybody. Welcome back to our podcast, If Bones Could Talk. It's a podcast by all the doctors here at Palmetto Bone and Joint. I'm Dr. James Logging, an orthopedic surgeon here at Palmetto Bone and Joint. And as always, I have Jackie Van Dam. Dr. Van Dam, thanks
Yep.
for being with me again
Yep.
today.
Yeah, we're excited to be back after a few weeks or months of missing out on
Yeah.
doing the podcast. We've been busy here at Palmetto Bone and Joint.
Yeah, things have been pretty busy. So, yeah, unfortunately, we haven't had the time to do our podcast
Mhm.
like we'd like to, but we're back at it today. And we've got a good topic, I think, to talk
Yep.
about today, something that really affects a lot of people. And we see it a lot in our practice, and that's going to be shoulder pain. So I know I see a lot of it. Dr. Van Dam sees a lot of it. So, Jackie, tell me a little
Yeah.
bit about some of the common shoulder issues that you tend to see when you see
Mhm.
people for shoulder pain.
Yeah, here at Palmetto Bone and Joint, many of us see shoulder pain. Dr. Wilson, Dr. Logging, Dr. Owens, myself, the other Dr. Van Tam as well. And typically, when people come in, the more common complaints of shoulder pain end up being forms of tendonitis or bursitis. Sometimes we'll see osteoarthritis of different parts of the shoulder. When you come in, we'll do a thorough evaluation physically and radiographically with x-rays to try to, hone down what's causing the pain. Occasionally, we end up telling patients that we think that shoulder pain might even be referred from somewhere else, like the neck or even from the muscles in the posterior aspect of the shoulder. So it is something really common.
Yeah, we definitely see it a lot, and like she said, a lot of the doctors here, between Dr. Owens and Dr. Wilson,
Mhm.
myself, Dr. Van Dam, and her husband, Dr. Van Dam, and Dr. Milner, we
Mhm.
all treat a lot of shoulder issues. Yeah, and the more common things people will see will be some sort of tendonitis or bursitis, and those things, don't necessarily need surgery, and a lot of
Mhm.
times they can be treated, conservatively, either with physical therapy, which is usually a very common treatment modality that we would utilize, working with a physical therapist to try to help improve the mobility in the shoulder and decrease the pain and improve strength, or injections.
Right.
And I know that's something that you will utilize a lot, and,
Yeah.
and injections can be pretty helpful, can't they?
Yeah, and I think the injections, especially, I had a few patients today that really it'll kickstart their rehabilitation program because eliminating some of that pain in the shoulder helps you sleep at night. Oftentimes, patients have difficulty sleeping on that shoulder at night. And, one thing I did want to mention with the therapy, because I had a few patients today asking, do I really need to go to therapy for the shoulder? Because they're hoping I could give them just a few simple exercises in the office that would eliminate the need for them to spend the time rehabilitating. But the shoulder joint is a complex joint with many small muscles that attach onto the bones. And oftentimes, even as I'm sitting here reminding myself, we have, poor posture sometimes with rounded shoulders, and you end up having an imbalance sometimes of, kind of how the muscles work about the shoulder. And that kind of contributes to some of the pain. So a good physical therapist will kind of stretch out the pectoral muscles and get your posture better and then really re-strengthen around the shoulder. And a lot of times the layering of those exercises really take a commitment, 4 to 6 weeks of really doing the therapy.
Absolutely. Yeah, it's not something that, unfortunately, with therapy is going to make better in a week. But I think your point about the injection can help really kind of jumpstart that recovery, because it does allow that pain to settle down, and it allows you to be more effective at the physical therapy. So I think that's a great point, that really the two of those things can really work in conjunction with that. Now, say you've come in, we've evaluated for your shoulder, and you've been through therapy and injections, but the pain's still not going away. What would be our next step that we would normally try, I think, at that point?
Yeah, and oftentimes after that step, we think, okay, we'll probably need more information with an MRI to see, are we dealing with more of a rotator cuff tendonitis? Is there more arthritis than we can see on the plain X-ray? Or, because sometimes I think, these partial rotator cuff tears or even, more significant tears, they're best seen on MRI, and that'll help aid in the diagnosis.
Absolutely. Yeah, so that's a pretty common thing that we would have to do. If we have gone through some treatment, it's not getting better, that's usually a sign that there's probably something more significant underlying that's causing that. So definitely we would want to get an MRI at that point. And, what we're looking at, like Dr. Van Dam said, is, for things that we just can't see on the plain X-rays. And that would be, a tear of the rotator cuff, tear of, tendon, the labrums, anything else in the shoulder to give us a look at. So, we can see on this picture here, This is just a picture illustrating pretty significant rotator cuff tear within the shoulder. And if you don't know what the rotator cuff is, it's basically a group of muscles. They come and they insert from the scapula and insert onto the proximal humerus. And they basically assist with movement and lifting the arm. And a lot of times those can either due to repetitive nature of use, or it could be to an acute injury. Those tendons can tear off of their insertion of the humerus. And the only way we can really tell that is with an MRI. And that can be definitely a reason that people's pain aren't getting better, because we definitely see a lot of rotator cuff injuries.
Yeah.
So obviously, if somebody did have a rotator cuff tear, unfortunately, that's not going to get better without surgery, because typically, as you can see in the picture, when that rotator cuff tears and that tendon tears, it retracts backwards. And so it just doesn't have the ability to heal. And so what we do is surgery, and usually that can be done arthroscopically, just with a few poke holes. You put the cameras in and repair that tendon back. So you're sewing it back down to the bone. And then that can really help make that pain go away. And that can make a big difference for people. And it's going to improve the pain, and it's going to improve their function so that they can get better mobility and strength back in their shoulder. Recovery for that kind of surgery does take about 3 months, typically, at least. And, sometimes can take up to a year for all of the strength to come back. But it can be a pretty successful surgery as well. So besides tears of the rotator cuff, there's impingement syndrome, which goes along with that as well.
Yeah.
And we see a lot of impingement syndrome. It goes along with rotator cuffs, but if we look at this picture, and there's the arrow that points from the subacromial impingement. And if we look at the bottom of the acromion, which is the bone there to the left at the top, you can see the spur that's kind of poking down. And that spur is what will lead to impingement. And so it rubs up against the bursa, it rubs up against the rotator cuff, causes tendonitis and bursitis, and can be pretty painful. A lot of times you can get that better with therapy, but sometimes you would have to go in and shave that spur out to help with the impingement. But definitely something you could try conservative treatment for as well.
Yeah. There's a lot of overlap with a lot of these conditions. So sometimes, we'll see patients and they say, well, I got diagnosed with impingement, and now you're saying there's a little bit of bursitis or rotator cuff tendonitis. And often as we age, we get a form of tendonitis, and we're already starting to get some early arthritic change of the AC joint and some early arthritic change of the glenohumeral joint, which is really that shoulder joint proper. So oftentimes it takes evaluation on the radiographic imaging, and then consideration of what might be the pain generator to decide, hey, do we think we can continue with therapy, or do we need to have surgical intervention? But one thing that Dr. Logan mentioned that I want to stress is that sometimes people with rotator cuff tears that have, they're starting to have significant weakness, they may not want to have the surgery, but then often later they've had a lot of atrophy of the muscles, and it's a little bit harder to do things when you've lost all that strength.
Yeah, absolutely. And nobody wants to have surgery, obviously, but once the rotator cuff tears and it retracts backwards, if you don't repair it fairly soon, like she said, Dr. Van Dam said, the muscle will atrophy, so that rotator cuff shrinks down, and then it gets scarred in that position. So after a period of time, it can be impossible to repair the rotator cuff. And in that circumstance, if people were having a lot of pain, then the only option to fix that would be a shoulder replacement, which would be typically what's called a reverse total shoulder replacement, which we'll talk about in a little bit. So I just want to put out there, if you are on Facebook and you're watching this, we appreciate you being here. If you have a question while we're going, we are kind of viewing those, the area on Facebook. Please ask a question. We'd be happy to try to answer that for you. But we appreciate everybody who's tuning in and currently, but we will be happy to answer any questions you might have. So just ask it away in the comments, and we'll see if we can get that answered for you. So, moving on, we started talking about shoulder replacements. Obviously, the main reason for that would be arthritis. Isn't that right?
Yeah. And, Dr. Logging, having done so many shoulder replacements, we were just talking earlier about, what is the difference with the more typical classic shoulder replacement, traditional, versus the new reverse total shoulder replacement that's newer surgically option that people, primarily benefit when the rotator cuff has been torn
Correct.
chronically.
Yep. So if you look at the picture here, we've got a total shoulder arthroplasty or replacement, which is the one on the left. That's the traditional shoulder replacement that you would typically use, and then the reverse is the one that's illustrated on the right. And the reverse shoulder, replacement is basically exactly like it says. It reverses where the ball is and where the socket is, and so it moves the ball to the socket side and the sockets on the ball side. And so what that does is it takes and puts that shoulder joint under tension. It makes it more like a hip replacement to some degree than a shoulder, but it puts it under tension, and it puts your deltoid muscle under tension. So what it allows for people who don't have a rotator cuff that's non-functioning anymore, it allows that deltoid to function like a rotator cuff. And so it allows that patient to get better mobility, better strength in the shoulder, and a lot better function. So it's actually a great design and evolution of the shoulder replacement to help people who do have rotator cuff pathology, because that's fairly common pathology, especially in somebody who has an arthritic shoulder. And if you were to put just a regular shoulder replacement in somebody with rotator cuff pathology, it wouldn't do very well, and they're going to continue to have pain because that's part of the problem. But the reverse really accounts for that and makes up for it. So pretty great, I think, design and evolution to really help people of that pathology. And, of the shoulder replacements, I do anymore, a lot of it's trended towards the reverse. And it has a really good success rate for that. So pretty cool design. And I think, it can help people, whether it's, the rotator cuff, the arthritis, or a combination of both of what they've got going on.
And we were talking about earlier, and one thing I wanted you to comment on was for that patient that's had a shoulder replacement but continues to have pain. If they come to see you, what might you find?
So I've seen several people, recently that have had shoulder replacement before and then continue to have pain. That can be a lot of different factors that go into it. But if they've had a traditional shoulder replacement, unfortunately, because the process of degeneration within the shoulder affects the cartilage, and that's why they were having the replacement to start with, it also is going to affect the rotator cuff too. And so, to expect that your rotator cuff's going to stay healthy when your shoulder wasn't healthy to start with, a lot of times what happens is people will either do okay initially, or maybe not even ever really do okay after a standard total shoulder replacement. And a lot of it is because the rotator cuff was never really healthy, or has become unhealthy and torn after the shoulder replacement. And so in that circumstance, there are things that you can do. And a lot of the newer technology with the replacements allow you to be able to transition and convert the standard replacement to a reverse replacement. So it makes it a lot easier. I mean, it is another surgery, but it does make it a lot easier with regard to converting one from a standard shoulder to a reverse. So there are options that can be done. If that situation were to arise. All right, so we've kind of talked about, rotator cuff pathology and tendonitis, impingement, arthritis, AC joint problems in the shoulder. So we kind of talked through all of those. A lot of shoulder pain that people get are related to the shoulder. Unfortunately, not all shoulder pain comes from the shoulder. And so it can be referred pain. So I know Dr. Van Dam sees a lot of patients that have a lot of referred pain, and she's very good at helping decipher where those referred pains come from, because a lot of it is nerve related, and it may take nerve conduction studies or EMGs to help her decipher that, but she's really good at helping us figure that out. So I'll let Dr. Van Dam talk a little bit about referred pain and where all that could come from. And
so sometimes you'll come in with shoulder pain, and we'll put you through the physical exam and x-rays and decide that you're not really hurting when you're moving the shoulder too much, but you swear the pain is just, you're grabbing your arm, it's right deep in the shoulder area. And it's sort of hard to get your mind around, me telling you perhaps that it's coming from your neck, but the nerves that exit the neck, especially if you have degenerative discs in the neck and you're starting to crowd where those nerves exit, I tell people, the problem's at the neck, but that nerve supplies the shoulder, so you'll feel it in the shoulder. And, it can take a minute to really get your mind around how that happens, because people really sometimes have to take that leap of faith that it is coming from the neck, especially if they're not having, numbness or tingling. But typically, you might have some of these nerve-related signs and symptoms like tingling, numbness, burning, things that kind of alert you that it's not just wear and tear arthritis or tendonitis. So, typically we might do another MRI either of the neck, or I'll perform a nerve conduction study to see, hey, are these nerves working that are supplying the shoulder, or is this, some crowding around the nerves that's causing the shoulder pain? And that can be treated, again, with physical therapy, injections for the neck, and even sometimes we end up referring patients to Dr. Davis, our spine specialist, and he'll end up having to do surgery to alleviate that problem around the nerves.
Absolutely. Yeah. It is hard for people to understand. And I get it. If you say, well, my pain is in my shoulder, but a lot of times the problem isn't coming from the shoulder. And so, you got to think about, if you lived on a river and somebody's upstream polluting the river, and you say, but my river in front of my house is polluted, you got to fix where the problem's coming from. Cleaning up the river in front of you is not going to help, because pollution is just going to continue to sweep down. And so a lot of times the problem does stem upstream. And so you just have to figure out where that's coming from. And that's where it can be confusing sometimes. If we've went through the process and we've looked at the shoulder and we don't really find a problem with the shoulder, then a lot of times it can be referred like that. And so it can be hard for people to grasp that. But, if you think about it, it makes sense, though, just because the nerve is referring that pain over.
Yeah. And sometimes for that, like I said, we'll do injections, or we'll even start you on some medicine for nerve pain, gabapentin, Lyrica, Elavil, a lot of medicines like that. And the good thing is they're so effective at treating the nerve pain that sometimes that also helps convince people, because it's not really a pain medicine. It helps more the nerve pain. But if they'll start some of those and they say, that really did ease up the shoulder pain, then sometimes that helps too. So.
Absolutely. Yep. No, I think that's a great point. What other, besides nerve coming from the neck, pinched nerves, what other shoulder, or I guess issues can cause shoulder pain?
Yeah, sometimes we see people, we call in physiatry, our specialty, more myofascial pain. So again, back to the posture, and a lot of us hunched over at work, and stress, and a lot of tight muscles up and around the shoulder. Sometimes it ends up that there's other muscles up near the shoulder and neck that are kind of referring that pain through trigger points in the muscles. And so, again, this is a case where, you might come in pointing to a specific area where you'll have tight muscles and dysfunction of those muscles, either shortening and chronic issues there that are helped by physical therapy. And one thing with a lot of myofascial pain, sometimes we'll do trigger points in the office for that. And then also sometimes people respond to physical therapy doing dry needling, kind of trying to break up those tight muscles and improve your posture, because so much of us now, so many of us are kind of hunched over computer screens and really doing a lot of desk work.
Yeah, that's a great point, because that is, unfortunately, with technology and things being on computers, a lot of people and their posture. I think it's great to mention, about the dry needling, with therapy. I think that can be very helpful for a lot of people, especially with myofascial pain, but a lot of different conditions that can be helpful for. So that would be definitely a great option for people to try. So, so anything else, or I think we've covered a lot of different topics with regard to shoulder. Obviously there's a lot of different other issues that could go on in the shoulder, between biceps tendon and labral pathology, instability. So there's a lot of things that could go on. These are just a few of the more common ones that we see. But if you're suffering from shoulder pain, you don't have to live with that pain, and it can be pretty debilitating and limiting when especially if it's your dominant arm, when you're trying to use it on a daily basis. But you don't have to suffer with that. I mean, there's things that we can do a lot of times conservatively that we can make it better. Or if the problem is bad enough, then surgery may be indicated, but you don't have to live with that pain. So, obviously if people are out there hear this and they're suffering from shoulder pain, please come in, make an appointment. Myself, Dr. Van Dam, we'd be happy to see you and evaluate that, determine what we need to do to get it better, because we can find a solution to make that pain better.
For sure.
Yep. So I think thanks everybody for tuning in. Again, we apologize that it's been a few weeks since we've been back here, but we hope to have them coming back to you here again soon, in another few weeks, with some more great topics. Again, if there's topics that you'd like to see, just leave a comment in this video, and we'll take a look at that, and we'll try to address those problems. Perfect. But we'd love to answer any questions you have. But again, thanks for tuning in, and we'll see you next time. All right. Thanks.
Bye-bye.
Thanks, Jackie.
Yep.
All right. Take care.